Good morning. Hopefully last but not least. I'm presenting today on transitioning a research tool into the clinical practice, the collaboration that we've been talking about this morning. And in our case, it's the use of the Edinburgh Cognitive and Behavioral ALS screen in the ALS multidisciplinary clinic. I'm the nurse counselor. I'm a licensed professional counselor on our team at Penn State. Historically, there's been numerous instruments that we've tried to assess the cognitive behavioral function in the ALS patients, but the information that we obtained, we just weren't sure what to do with it. So this particular assessment, the Edinburgh Cognitive Behavioral ALS Screen, which from now on is called the ECAS, was developed and validated with the author being Dr. Sharon Abrams in the UK, but it hadn't been checked for feasibility and usefulness in the clinical setting. So when our neurologist, Dr. Zachary Simmons, and Dr. Abrams collaborated, it was decided that we would be the initial clinic to see how this worked. We had three major objectives. The first was to see if the administration of this ECAS in a multidisciplinary clinic, if we could really apply the results in caring for our patients. The second was to understand if these ECAS results would actually support the health team. How do we talk to the patient that has issues so that they can better understand the many recommendations we're giving them? And the third was to use the ECAS results to better help the family, to help their caregiver, to keep them safe, and to give them the best possible quality of life. Just to look over the contents of the ECAS, the cognitive is divided into two domains, the first being the ALS specific, and most of the past assessments were not ALS specific. And those three areas that we find are most concerning are the language, the word fluency, and the executive functioning. As said a little earlier, they have a difficulty finding the right word to put to the right object. They have difficulty maybe completing their sentences. They may talk in phrases more frequently. And with executive functioning, they may even pull back from wanting to make decisions, but if they want to make decisions, are they able to weigh the consequences that come with those decisions? And the second domain for the cognitive is the ALS non-specific domain, which looks at the memory and the visual spatial. In the times that we've used this in our clinic, that area really hasn't been the focus, and we haven't seen much with the memory or the visual spatial. With the behavioral domain, it looks at disinhibition. These patients may have been very mannerly in the past, and now they make a lot more crude remarks, or they want to put what they believe on you in a more confrontive manner, such as with politics. This is what I believe, and you will believe it. There can be some sexual innuendos with these patients. Apathy and inertia, they're not as motivated. They really have no desire to do things that they still could do physically, or they start things and then they just don't finish them. Loss of sympathy or empathy, the example we hear most frequently, especially if it's a female caring for her spouse, is he makes hurtful remarks. Here she is picking up all these extra roles, trying to do the best she can, and the comments are negative. They perseverate, have more stereotypic ritualistic behaviors. In other words, this is how I want my day done. You have to do this before you can do that. And when you're trying to balance being the two people for one, that becomes difficult. Hyperorality and altered food preferences refers to someone may have been a very healthy eater before, and now they're craving the carbs, the junk foods. Or it could be vice versa, but you don't hear that as frequently. Or they may be binge eaters, people stuffing food in their mouth like chipmunks, and choking because they're not swallowing as well. or they just may get stuck on a food and just want to keep eating and eating and eating that food. As far as the psychotic features, from the assessments that we've done in the clinic so far, we don't see that as frequently. The one that periodically comes out is paranoia. And again, that's usually if the spouse is caring for her husband and she goes out grocery shopping or she goes to get her hair done or whatever, and when she comes back, he accuses her of doing other things. So the methodology was, first of all, we needed to figure out how are we going to do this. This was totally new to us, and Dr. Simmons had spoke with Dr. Abrams, and it was decided that we would do a pilot study, first of all. And my colleague is here in the audience, Dr. Travis Haynes, and he's a research coordinator, and I'm a licensed professional counselor nurse. So we piloted this. We each went back and forth who did which one. And we found that we had questions. So at that point, we Skyped with Dr. Abrams, and we decided that it was time to do the real thing. The questions we had, she answered, and we went on to start doing them. After we had finished, I think, between 15 and 20, we Skyped with her again, and this time we went over what we had accomplished, and she asked that we send them in now so that the grading could be done similarly. This was going to become a hopefully national protocol, so everyone needed to be doing it the same way. So we did, and she looked over the way we graded it. Most of it is not subjective, but there are some areas that you have to translate, and we wanted that to be all the same. So after we did that, we were determined to be certified by her so that we could administer these. Then it was establishing a protocol within our own institution of the how-tos. And we decided that the first visit was definitely too stressful for the patient. So much information was being given to them, and we decided the second would be the best target. And if indeed the patient was in fairly good shape at that point, and they weren't overly depressed or overly anxious or overly fatigued, and that we were available, we did it on the second visit. If not, then we did it on the third visit. And it became important that we had a protocol so that the team knew when this was going to be accomplished. There are exclusion criteria which are spelled out very well in the protocol. These are such things as a prior extreme mental illness that was still ongoing, alcohol abuse, drug abuse, if they've had strokes in the past, uncontrolled diabetes, et cetera, et cetera. Then we decided that Travis was going to do the cognitive portion, and I would take the family out and do the behavioral at the same time. That was so that the caregiver can be in the room for all the other health professionals when they come in, and that indeed we each have time individually with the patient. And since I'm the nurse and the counselor, we felt it was best that I do the behavioral because the caregiver could get closer and be more confident and have a bonding with me, so she knew I would walk this walk with her. She would be more open and maybe connect with me more frequently. So we did that, and our plan was to try and score it through the clinic, the remaining time of the clinic, but if we didn't get it scored completely, our one objective was to share it with the other health professionals on our team. So by the time we had gotten through as many as we've done now, which is between 90 and 100 of these assessments, we're able to look over it and at least give our team a general idea of, yeah, we're really concerned, or no, we think things will look okay. We do put this in our power charts, so if in between the next visit, the other healthcare team needs to find out what the real results were, they can go back there and see. So the communication with the team does definitely have a relevance to the way they present the recommendations. We always laugh because we send out recommendations at the end of every clinic. And sometimes if you look back historically, you see these same recommendations every 3 to 4 months. And so what we've learned from doing this is that if the patient is having cognitive issues, we need to speak to them in a different way so that they can comprehend what we're really trying to say, as well as the caregiver, that the caregiver can get the message. It's not safe allowing him or her to carry the laundry basket up and down the steps, or it's not safe for them to be driving, this type of thing. So the next portion was the communication with the family and the caregiver, and as I do the behavioral with the caregiver, I'm pretty much aware of whether there's issues there. So I use that time to help give strategies to maybe lessen those issues with the caregiver while I'm speaking with her or him. And also I assure the caregiver that if there are severe cognitive issues that come up as a result of the other portion, that in between I will speak to them on the phone and we can come up with some better ways to handle things. I also offer one-to-one time for that caregiver, give them my phone number and my email address, so if new things come up, that they're willing to share so we can talk this over and not wait until the next clinical visit. The most important part of all this, I think, is that we no longer are really looking to diagnose this patient with another diagnosis, such as frontal temporal dementia. Yes, this can be brain changes, and yes, we're getting information, but it's an assessment tool. It takes about 20 minutes in the clinic. It's to help us help the caregiver and to help us help the rest of our team to give the best care possible. Some of the major areas situationally that have come up as a result, one of the biggest things that made Sue Walsh, who's our coordinator of the team, and myself get really interested in this several years ago was the fact that we had a woman who was running a business with her family, and the family was just so sure she was doing all the books and all the checks and everything else, and he was so sure that everything was running smoothly. And we could tell in the clinic that something just wasn't right here, and we didn't have the ECAS back then. So we talked with the family and again encouraged them that somebody should try to oversee the financial part. Well, at the very end, they were very, very much in debt. And we decided that this was one area that we needed to pursue even more. So financially, these patients are very vulnerable. They give out a lot of information that maybe they shouldn't be giving out. They may be opening credit cards that they shouldn't be opening up. They're spammed much easier. We've had several spammed over the past few years. So very important. As far as driving, our patients, PT and OT assess them, as well as, of course, the physician, but this has helped validate their feelings. Sometimes they just can't pinpoint what's going on, but they don't feel that the patient is safe driving. And so if we see they have cognitive issues or behavioral issues, this also helps. We have patients that are working in high-profile financial positions, and I don't think I'd want to know that this person is investing my money if they're having severe cognitive issues. So again, another help. And the last one is the personality changes. If the wife is telling us that they just are being so nasty, it's very hard to deal with them in the same loving way. But if you're able to tell them that things didn't look as good on the cognitive side of it, they are a little more understanding, just as they are with the ALS. They don't get quite as frustrated. So the plus and the minuses are we've successfully administered over 90 of these ECAS assessments. It takes approximately 15 to 20 minutes. Now, if they're texting, because the bulbar can be tested as well, it takes a little bit longer, but it's still just as relevant, and that we can share these scores with the team. It's helped us develop new strategies for teaching the patients and the families, especially the caregivers, and it's given me one-to-one time with the caregiver, and the caregiver is more likely to share things that, thank goodness, she wouldn't want to share in front of the patient. And it now has been adapted as our standard of care for screening in the ALS clinic at Penn State. So our future plans include the longitudinal comparison of the ECAS and the former ALS CBS And we're hoping that, as strongly as we feel about this, that this is going to become a more prevalent form of assessment in many other clinics. Thank you. Questions?
Thank you. This is now open for questions.
Suzanne Gilroy with the North Carolina ALS Association. I have a question about if you do or how you relay any information about cognitive changes to the patient themselves.
We try not to do that. We have done it. And the thing about this particular type of patient is that many times they're extremely intelligent people. And so when we tell them we're going to do this assessment, and we tell them we do it to every new patient that comes to see us, that kind of opens the door. And we did have a patient say to us, and I want to know the results. And so, of course, as much as I tell the families if there's issues, that I didn't feel comfortable doing that. So Dr. Simmons and I spoke with the patient and the caregiver, and it wasn't good. He argued, of course, all the things that you find in the assessment came out. So how I present it now when I tell the patient that we're going to be doing this, I usually tell them at the end of the first clinic that the next time they come, I may or may not be doing a little assessment on them, that we do this to every new patient. And if they say to me, I'd like to know too, I have to do that, but I do it in the sense that at the next visit, I just say to them, well, I think that there were some areas that weren't as good as others, but we're going to work on how to overcome those things to deal with them in the best way. So we try not to share with the patient. We want to respect them. And that's all they need, is to know that one more part of them isn't like it was before. Thank you.
Hello, I'm Maxine Sloboff from Minnesota and the ALS team at Hennepin County Medical Center. We present this protocol. We were part of the multi-center study. So we also presented this assessment, and we speak in the same way. We do this with every patient. My question to you is, as you share the information, after you present the assessment, and you mentioned that you share it with the team, and we have an after clinic
wrap-up
rounds.
Mm-hmm.
How do you present it to the team on the same day of the clinic so that the physicians or providers could provide that information back to the family? Number one. And you did mention that you do speak with, or that it's a very delicate situation in terms of talking with the PALs themselves. But I feel it's important for them to understand that there is a process going on. But please let us know how you present it to the family on the same day of the clinic that you assess.
Right. We are not usually able to do that. What I think I said was that we try to at least we look over the scoring. When I'm doing the behavioral part, it's either obvious that there's a problem or there's not. And that's an educational time. Sometimes the caregiver will say, well, that's not really what happened, but this is what he's doing. And then I can try to work on a few ideas for that particular thing. As far as the cognitive, I tell the caregiver at that time that if concerns come out of the cognitive portion, when we get to have it scored, that I will call them on the phone and we will discuss that with them in between the visits. And actually there was one at one point that she wanted her husband to be on the phone at the same time. So we do honor that as well, but I put it in a language that these are just a few areas of concern. Again, it's to help give the patient the best quality of life with the most respect we can possibly give them. It's not about hanging another diagnosis on them, because this is a 20-minute assessment. It's not the 4-hour cognitive behavioral actual test that can be done for them. Does that make it sound clearer for you? Thank you. Mm-hmm.
Hi there, I'm Rachel Boothman from the MND Association in the UK. Just wanted to ask you, when you've actually identified using the tool that there are cognitive issues there evident, you talked about the management techniques that you discuss with the caregivers. Can you just tell us a little bit more about that, some examples, and do you follow it through with any literature or any guidance at all?
So you're asking for more examples of things that we may discuss with the family, of strategies?
Yeah.
Okay. Well, the first big one is the financial. And truthfully, with any ALS patient, there's no better time for which, if the spouse is not doing the financial in the family, there is no better time than the present with the diagnosis of ALS for that caregiver or loved one to learn how to do the finances. And I strongly encourage that with every ALS caregiver, and you can say it in a way, honey, you may not be able to do this in the future, and I take a long time to learn, so you've got to show me. Let's go over it and over it and over it, because many people are doing it on the internet now. And so it still gives them the respect that they still have something they can share with you, but at the same time, you're seeing what they're doing, because it's just mind-boggling to me how many of them can kind of make everything look normal until somebody later has to go back in and see that it's not normal. The same way with getting caregivers involved. That was one of my other examples that I didn't allude to. Many times the spouse will say, I don't want anybody else in here taking care of me. I just want him or her to take care of me. And so when they have behavioral issues and I'm speaking with the caregiver, I'll say, you can kind of see that your loved one isn't going to step up and say, get caregivers in the house. You're going to kind of have to stand up, get up to the plate and say, I can't do this. I really don't want to get sick and end up in the hospital. I have to have help. That you have to take responsibility for wanting it instead of thinking that they're going to make the decision to do it. And so these things have been helpful in kind of getting the caregiver more empowered to do things when they realize that there can be issues. On the phone, when they've totally denied, when they'll say to me, and I'm doing this, oh, there's nothing wrong with him. He's doing fine. He's still working and all this stuff. And then when I have to call on the phone and I'll say, remember we talked about a few of these things? Well, he maybe is doing fine, but he needs you now to oversee because there are some areas that are concerning to us that maybe it isn't as good as you were thinking. And so then they start to realize that maybe some of the things that they have seen are clicking together. Well, I ignored this, I ignored that. Maybe they've got a point here. But we are defensive for our loved ones, not only with the ALS, but definitely if there's cognitive behavioral changes. That's, even though this controls everything, we don't want to admit that there's a problem there.
All right. Well, Well, you can ask one more question. You'll keep everyone from morning tea.
Is there a large percentage of patients that refuse to take this test?
The question is, there a large percent of people who refuse to take the test?
No, actually, in the year and a half, going on 2 years that Travis and I have done this, we've never had any refuse. It's amazing to me, but truthfully, our ALS patients will do anything you ask.
So
Yeah.
just a reminder that everyone's email address is in their bio in the book. So if you have questions that weren't answered or you think of them later, feel free to email our speakers later.
Thank you.
Thank you.